Good evening, everyone. This is Meldita, and this is a continuation of our PEA. And this time, this is about the causes of PEA, the H and the T's. So on the T side, the T's here, we have here the cardiac thrombosis, like the acute ischemia or myocardial infarction. When they go to the cath lab, they found that there is a clot sitting on top of this plaque, and it's totally covering or occupying the whole lumen of this coronary artery. Then we have a myocardial infarction, okay, and there is also this pulmonary, the pulmonary embolism. So there's a big clot sitting in the pulmonary artery, and that affects the supply going to the heart muscle. We have also tamponade. Okay, and this tamponade is during, insertion of tubing or catheter and accidental poke of the pericardial area. So blood will accumulate into the pericardial cavity. So we have what you call this one, continuous accumulation of pericardial effusion that leads to a tamponade. Okay, and tension pneumothorax. Okay, and that's probably from trauma. Okay, we have toxins like the use of street drugs. We have tablets like the beta blockers and the calcium blockers that affect the heart muscle. And among the H, we have actually hypoxia secondary to respiratory failure. We have hypovolemia and hydrogen ion concentration. Number is high. Either we have respiratory acidosis or metacidosis. We have also hypokalemia and hyperkalemia, hypothermia, that is prolonged exposure to the cold environment. And sometimes they include as well here hypoglycemia. Well, in the case of a true PA, what happens that we have why a myocardial contraction fails, because we have also a decreased ATP delivery, the high energy phosphate, and then that will lead to a decreased myocardial contraction and no palpable pulse and end up to a cardiac arrest situation. Okay, and usually the hypoxia and the hypovolemia fall under the PSEUDO-PEA. Okay, they have contraction and they have also a little bit of aortic pressure. Now, with regards to the management of the PEA, there are three groups that deal with this problem. So we have the first responders, the RNs, and we have the doctor and the respiratory therapists, and the nurses. So far they work as a team. So one will call the code blue, one will start the CPR, one will start recording, one will bring the crash cart and hook the patient to the defib monitor, one will start an IV and will get another IV site, one will request for stat blood works, ECG and chest x-ray, one will prepare an epinephrine IV standby for use by the doctor, and there is also the portable tablet echo machine that will be used by the doctor upon arrival. So when the RT and the doctor arrives, the RT will actually the start of a two-man rescuer. So the RT will do the back mask or the ET mask ventilation to eventually maybe intubation to a ventilator. And the RN will do the chest compression. And here we have the doctor that will surely be giving 99% an IV epinephrine. That is to create a good contraction, heart contraction, and to increase the blood pressure, because the epinephrine works as a chronotropic, affecting the heart muscle and also to the alpha side of our blood vessels that will increase the blood pressure. So it vasoconstricts the blood vessels. And also with low volume, circulating volume, usually they will manage this with intravenous fluid bolusing, like for normal saline. And low hemoglobin, there will be a blood transfusion and further investigation of the possible source of bleeding. High potassium, that will be by the renal patient, that will be dealt by insulin and D50 IV. Low potassium, like over the uresis or anything, K supplement IV and a simultaneous magnesium IV. And we have also here pericardial tamponade. That's probably secondary from any catheter, invasion or invasive procedure that's poking the pericardial area. Then there's a immediate pericardial effusion accumulation, and that is continuous and leading to a tamponade. So the doctor will do pericardial synthesis guided by an echo. We got also pulmonary embolism. They could either give this with IV thrombolytic or maybe a stat referral to the vascular surgeon or to the cardiac surgeon, and they will probably open up the patient and will do embolectomy if they will. And then there is a tension pneumothorax, and there's a stat referral to the respirologist and possible chest tube insertion. And if there's an acute ischemia or whatever, like we have here infarction, and still the same is unconscious or anything, so the patient will end up going to the cath lab. They will do an angiogram, and if they see there's to be stented, they will do the stent. If not, and maybe open heart surgery, like bypass, they will do it, and the patient will probably come out of the cath lab with possibly with intra-aortic balloon pump. Okay, so if you see here, there is a two-man rescue here. So we have the RT doing the bag mask ventilation, or the endotracheal mask ventilation here. So that is the what you call the bag mask or the ET mask ventilation to the ventilator. We have here the solo here, the nurse. You cannot do ventilation here because you're pushing the air out. It's just useless. Just deal with your chest compression here until the doctor arrives. This will take fast because this is a code, this is a code blue thing. In a minute or two, they are already at the bedside, and they'll do their immediate management to the patient. Okay, so as I said again, if this hypoxia and hypovolemia, usually they fall under the PSEUDO-PEA. Usually, they have mild contraction, they get a little bit of pressure. So what they do, they will give a stat IV epinephrine to bring up the contraction higher and also the blood pressure higher. But for the true PA, which is a cardiac arrest, then we'll go ahead with our algorithm with that. Okay, so hopefully this will help, and thank you so much again, and till next time. Thank you.